Hello, I'm Sarah Maxwell reporting for Cancer Spotlight from the European Breast Cancer Conference in Amsterdam. We've been hearing about a way of predicting which patients with HER2-positive early breast cancer could be treated with anti-HER2 therapy alone, added to their surgery, without needing any chemotherapy. Judith Bliss told me their UK-based EPHOS B trial found that looking for response to preoperative therapy with an anti-HER2 combination like lapatinib plus trastuzumab could hold the key.
The trial was originally designed as a 3-part trial, so this is patients newly diagnosed who are scheduled to have their surgery in approximately 2 weeks' time, and they were allocated either to continue standard of care waiting for their surgery, or to receive trastuzumab, or to receive lapatinib. You can get those 2 drugs in combination, but at the time we started the study, we didn't feel there was sufficient information to reassure us on the safety, particularly the safety of delivering these 2 drugs in combination to what's a group of very well women, apart from the fact they've just been diagnosed with breast cancer. But partway through the trial, that information had become available. So we amended the protocol to replace the single agent lapatinib group with a group who would receive lapatinib and trastuzumab in combination. In the meantime, there'd also been further evidence suggesting on the efficacy of that combination, but particularly on the safety was our primary concern.
So what were the results then? What have you seen looking at these 3 treatment options?
Well, we were looking to see whether patients had at least a 30% drop in that Ki67 marker. And that was shown to occur in over a third of patients on trastuzumab, and just under 2/3 of patients on lapatinib, and about 3/4 of the patients on the combination arm don't observe that demonstrable response in Ki67. But whilst we were performing those analyses, it also became clear that we were actually essentially missing the second sample, the tumour sample at the time of surgery, for a group of patients. So we clearly needed to ask why we were missing those samples. And it became apparent that particularly for a small group of patients, but particularly in the combination arm, there had been no invasive tumour left at the time of surgery on which to actually perform an analysis of Ki67. So that really allowed us to go back and look at the local pathology reports of all the patients in whom we were missing a Ki67 measurement, and to ascertain that we have a group of patients, about 10%, for whom there appears to be no evidence of invasive tumour left after that 11 days treatment with the combination therapy. And a further group, about 17%, for whom there's only what we call minimum residual disease, so less than 5 millimetres of invasive tumour left at that time. This occurred in about 3% of patients with trastuzumab, but equates to about a quarter of the patients who are treated on the combination arm.
So potentially we're looking at being able to personalise treatments early. What are the real-life clinical implications here for practice?
So the first implication is further long-term research, and research that will investigate long-term disease outcomes, so the probability that the cancer would come back and the overall survival, but particularly the long-term probability that the cancer would come back. Those are the endpoints of further trials that we need. So if we can do a little bit more work on the biology now to try and understand this group better, and then perhaps run another trial where patients receive a biopsy at the beginning, they receive their 2 weeks of combination anti-HER2 therapy, they receive another biopsy, and if they have appeared to be in this group or having this exquisite biological response, we will perhaps aim then to randomise them to continue with standard of care or to proceed with, for example, further targeted anti-HER2 therapy, but perhaps avoiding the need for cytotoxic chemotherapy.
It is very exciting, but these numbers are relatively small. Is this enough, really, to change practice?
Yeah, I think you're quite right to have scepticism here. The numbers are relatively small, and remember this trial was set up that all the patients in the study would go on to receive standard of care treatment thereafter. So all these patients who had the PCR went on to receive chemotherapy as part of their standard of care. So before we can start saying this patient doesn't need chemotherapy, we really do need further trials to actually formally compare the avoidance of cytotoxic chemotherapy against the complete package, which has really improved outcomes so much in recent years. It would be a real retrograde step to go back on that at the moment. But this does offer us the potential in the future to identify a group of patients who could be particularly targeted a treatment around their response to anti-HER2 therapies.
Judith Bliss from the Institute of Cancer Research in London. At the Breast Cancer Conference, Karen Gelman from Canada told me she thought using the preoperative window to test whether you could spare your patient chemotherapy might not be ready for prime time just yet, but looking for rapid Ki-67 response and tumour regression to brief anti-HER2 therapy is promising.
The new thing that it tells us is that you can find these very early, and most studies have looked at it later. The combination of lapatinib and trastuzumab has been looked at before, and all in all is no longer thought to be the optimal combination. But I think these kinds of studies showing response early are helpful in terms of developing new agents.
How do you see this potentially impacting the way we approach these patients?
So I don't think it'll change how we approach patients. I think what it is a framework for the UK group and other clinical trials groups to do subsequent studies in new agents looking for early response. If we can find early response, then we might spare doing some of these larger trials for inadequate drugs, or we might go ahead with more enthusiasm for drugs that show promise. So I think this really is a framework for doing future trials, more than telling us anything new about these agents.
Karen Gelman from the University of British Columbia and the BC Cancer Agency in Vancouver. For Cancer Spotlight from the Audio Journal of Oncology, I'm Sarah Maxwell.